Yet again, on behalf of Indian Chess Society, I welcome you to another webinar of ICS. ICS is committed to providing an in-depth understanding with take-home messages at the end of every webinar. We are conducting a series of webinars which are very informative and will bring you a lot of information. Indian Chess Society presents this webinar on pediatric asthma. Today's webinar is supported by CIPLA. Before starting the webinar, I would like to convey to all our members that NAPCON 2023 Delhi registrations are now open. Can we please have the slide of NAPCON? As you see, the NAPCON Delhi registrations are open, so get yourself registered right now before time runs out. Now, I would like to welcome one of our moderators, our very own Dr. Indranil Haldar. He is the consultant pulmonologist and pediatrician, HOD, Department of Pulmonology at JNM Medical College, Kolani. Sir, I request you to go ahead and begin the session. Over to you.
So thank you, Wendila, for the kind introduction of myself. So I am a member and the governing body of the Indian Chess Society. And good evening, everybody who are there with us, and a warm welcome from Indian Chess Society. So today our webinar is on pediatric asthma. In fact, we may think that most of the members here in ICS are adult pulmonologists, but why should we know about pediatric asthma? In fact, it's sometimes that we may be getting cases of pediatric asthma referral, but it's important that asthma starts in childhood and we should be aware, yes, how to diagnose them, and the most important aspect of counseling. To be with us, we have our Madam Dr. Bornali Bhattacharya, who will be dealing on the counseling part of pediatric asthma. And she is I can name any adjective after her, but the most important thing is that he has been practicing pediatrician for the last 30 or 35 years. The mission of life is to give back asthmatic children the near normal life. And she is the course director of the Casper Crest. Our second topic will be on the diagnosis of pediatric asthma. This will be by Dr. Sushant Mane. He is the associate professor in pediatrics and in charge of the pediatric asthma divisions, nodal officer of the State Pediatric Center of Excellence for Tuberculosis of Grand Medical College Sri JJ Group of Hospital, Mumbai. He is also an expert in the National Technical Expert Group, National Tuberculosis Elimination Program, and member of the Child and Adolescent Tuberculosis Work of West Bengal. We have with us as panelists who will be moderating with me, Dr. Atanu Bhadro, and he is not only my dada, but he is also the guide, the brainchild for the AsthmaCon that we'll be having in Kolkata in the next month. And Atanuda is the Vice President of the IIP 2021, National Scientific Coordinator of the Action Plan 2023, Past Secretary of the West Bengal Pulmonology Chapter of West Bengal Academy of Pediatricians. And we have also Dr. Shoibal Moitro, who will be joining with us. And Dr. Shoibal, the most, in fact, he is an adult pulmonologist. He is an adjunct professor and senior consultant of Apollo Hospital. And what is important that he is trying to streamline the allergic training all over the country. He is the brainchild of the DAI course in Kolkata. And not only that, he is a joint program faculty and member of the body of the DAA, which is done from CMC Vellore, DPAA Ganganam Hospital, Delhi, and FAI AIMS Rishikesh. So he is the course director and also the joint program faculty of all these allergy courses that are running all over the country. So with this, I'll be starting the program. With first, I'll be asking Dr. Sushant Mane to please give his lecture. Dr. Sushant?
Yes.
Please share your screen and...
Yeah. I hope this is visible.
Yes, yes.
Yes. So at the outset, I would like to thank ICS, Indian Chess Society, for having all of us here together on a common platform of pediatric asthma. And I will thank Dr. Haldar sir for that kind introduction. So we are all learned practitioners here, and being pulmonologists or pediatricians, asthma we have been dealing with throughout our lives. What differentiates pediatric asthma from adult asthma is what we are going to highlight today in the next 20 to 25 minutes. Because what we see in common practice is most of the time what happens is the cases of pediatric asthma linger around for quite a bit of time, maybe a few years sometimes, before it is actually diagnosed correctly and the child finds the right treatment for its asthma. So when we talk about pediatric asthma or diagnosing of asthma in children, we arbitrarily divide children into two age groups: children up to 5 years of age and those above 5 years of age. Now, why this distinction is made as far as diagnosis is concerned is, now if we recollect our knowledge, basic knowledge, asthma, the most common presenting symptoms of asthma are cough, wheezing, breathlessness. Now, if we see children up to 5 years of age, there are a n number of disorders related to the respiratory tract, which will present with a combination of one or more of these symptoms, that is cough with breathlessness or cough with wheezing. So what do we mean by this is, there is a lot many differential diagnoses when we talk about cough and wheezing in a child less than 5 years of age. Not only asthma, we have a long list of other DDs. There are many wheezing disorders. We have GERDs, which can come with wheezing. We have congenital hearts presenting with respiratory symptoms. We have congenital lung anomalies. So there is a long list, and therefore the diagnosis of asthma is one of the DDs. Second thing, as we all know, the objective test for diagnosis of asthma is spirometry or pulmonary function test, which a child less than 5 years of age is not able to do. By and large, a child 6 years and above can be trained to do a pulmonary function test. And therefore, when we talk about diagnosis of asthma in children less than 5 years, it is a little different. There is a little different approach, and it is a little different, difficult ballgame to crack the diagnosis. As opposed to that, if we have an older child, the child will be forthcoming with his symptoms. The parents would be able to define the symptoms in a more appropriate way. And yes, we also have objective tools like spirometry and PEFR, which in a clinical background or clinical setting of asthma, we can use these tools to have an objective diagnosis of asthma. So coming to diagnosis of asthma in children up to 5 years of age, now there are three factors on which this diagnosis is based. One is the classical symptom pattern. Then we look into the risk factors, which we have to hunt for. And then there is something known as therapeutic trial. We are going to see each one of these in details. So when we talk about symptom patterns, the cardinal four symptoms, when we talk about asthma in children up to 5 years, we have cough, then we have wheezing, difficulty in breathing or shortness of breath, and reduced activity. So these are the four features what we will be looking into. Risk factors, yes, we have to look into the past episodes, whether the child has recurrence of these symptoms, because recurrence is very important. They go on occurring with a asymptomatic gap in between. There are certain familial factors, genetic factors, which we are going to see in the forthcoming slides. And third, but not the least, a therapeutic trial, because as we said, we do not have an objective diagnosis like a spirometry. When we have a clinical symptom complex, suggestive, or more likely to be asthma in a child under 5 years, what we do is a therapeutic trial. So when our child has any three of these symptoms in combination in a recurrent fashion, now how do we define recurrent is, if the child is having more than 3 episodes or 3 episodes of these symptoms in a span of 1 year, we can suspect that this child is probably having an obstructive airway disease, which is reversible. And the commonest diagnosis of an obstructive reversible airway disease is asthma. So when we look at these 3 symptoms, now we want to delineate, because like we said, cough and breathlessness can come with many other conditions. So what kind of cough or what kind of breathlessness would point more towards asthma, we have to hunt, and there our history is going to help. So as we have always learned in our basic clinical medicine, history taking is very important. Coming to the first symptom, that is cough. Now, if I want to give you figures, cough is the most common presenting symptom as far as pediatric asthma is concerned. Around 90% of kids are going to have cough as one of the presenting symptoms. It can be in combination with other symptoms like cough with wheezing, which is the most common combination, and cough with breathlessness. Around 60% of children may present with only cough as their initial symptom for an initial few weeks or months. Why I'm highlighting this is because, when we think or when we read about asthma, now the Hindi word or the Hindi synonym for asthma is dama. Okay, so that the derivative of asthma also come from dama, and dama means to have breathlessness. So there is a common notion, not only in the patients, but sometimes, that gets fixed into the minds of clinicians, that unless and until there is breathlessness, we can't label that this child could be asthmatic, which is not the case. As we said, 60% of the early symptoms, early asthmatics may have only cough as a presenting symptom. Having said that, which kind of cough would be pointing more towards asthma? So the cough would definitely be a recurrent cough, that is with an asymptomatic periods in between, a predominantly dry cough. The characteristically, the cough of this obstructive airway disease or asthma would be worse in the middle of the night or early mornings. That is what the history the mother will give. Now, when we talk about small kids like infants, 1 year old, 2 year old, 3 year old, in the counterpart of exercise or outdoor play in them is crying and laughing. So if we dig into the history, the mother sometimes gives the history that doctor, after a bout of crying or after a bout of continuous laughing, my child goes on coughing for a few seconds or minutes, which just doesn't stop. So this should signal our brain that something is going wrong, because normally a child would not be coughing for such a long time, maybe 1 to 2 minutes or 3 minutes after crying or laughing. So this history is very important, which indicates increased work of breathing. It may or may not be associated with wheezing. As we have just said, it can be the only presenting symptom in the early stages. Even in the absence of respiratory infection, the cough will go on. Why we say this is because in our country, the most common trigger for asthma symptoms to come up is a viral upper respiratory infection. By and large, we all know that when we have a viral upper respiratory infection, it goes off within a period of 7 to 10 days. However, if apart from all the symptoms have waned off within a period of 7 to 10 days, but the cough is still persisting beyond 10 days or beyond 2 weeks, we should start thinking that something is going wrong in the child. Response to bronchodilators, believe me, all of the symptoms of asthma, whether it is cough or wheezing or breathlessness, will have a dramatic and excellent response to a simple bronchodilator medication, either a syrup or a tablet. By bronchodilator, what I'm talking about is Astelin or salbutamol. Just a small dose of salbutamol once or twice a day would be the child would be having a dramatic reduction in the symptoms. Now, having known what points towards asthma, we should also know what kind of characteristics of cough take us away from the diagnosis. So if the cough is predominantly a productive cough, if most of the times the cough and airway symptoms are associated with fever, because fever indicates infection, if you do not find a diurnal variation, so this is not hard and fast. Some children may not have a diurnal variation, but yes, by and large, patients will tell or parents will tell that the symptoms are prominent in the middle of the night. It is not exercise induced or it is not aggravated by triggers. This is a very important factor. And in spite of giving bronchodilators in appropriate dose, there is no appreciable response to bronchodilators. So these are the things which take us away from the diagnosis of asthma. Talking about wheeze, again, the same things recur. The wheeze would be present even in the absence of a respiratory infection. It would be recurrent. It would be also present in sleep. An asthmatic child with active airway inflammation would also have wheezing during sleep. It is triggered again by laughing, crying, exercise, may or may not be associated with breathlessness, and it responds very well to bronchodilators. Now here there is a disclaimer. We must remember that all asthmatics do not wheeze. We just learned in the beginning of this session that most common presenting symptom is cough. So even if the patient is having only cough without wheezing, we still cannot rule out asthma. Vice versa is also true. All wheezing children may not have or may not fit into the diagnosis of asthma. Why we say this? Because as we discussed right in the beginning, less than 5-year-old, the differential diagnosis of cough with or without wheezing is large. And therefore, we have to have our mind broadened, okay, to all the possibilities. And that is why a good history taking an examination is important, so that we don't miss any other symptoms or signs and we don't wrongly label a child as asthma. When patients, what happens mostly in a asthmatic wheeze is, when the child is getting symptoms, say suppose in the middle of the night, the child will have symptoms. And by the time the parents get the child to you in the morning next day, the patient will not have any symptoms. This is the common scenario which we see. He may have cough, but the wheeze may have disappeared. So actually, when we want to confirm that the child was actually wheezing and it was not just, snoring or sound because of nose block, it is always better you ask the parents to get a video recording of the wheeze so that it is definitely confirmed, yes, this was a wheezing episode into the child. Shortness of breath, again, same. It will be occurring with triggers, with exercise, recurrent symptoms. By and large, if the child is not into an acute exacerbation of asthma, there won't be any cyanosis, because most of the times it is not, shortness of breath is not that severe if the child is gone into a mild exacerbation, and it would be accompanied by wheezing or rhonchi. So the point of discussing all these symptoms is, when we have a child in front of us, we have to dig into the history of each of the symptom in detail so as to pinpoint whether we are looking towards an asthma diagnosis or away from an asthma diagnosis. Now, in addition to these cardinal symptoms, there are certain corroborative histories which we must be finding out from the parents of the child. Sometimes, if the parents are well educated enough or knowledgeable enough, they will come with the history. But if they are not, then we have to ask leading questions to the patients or parents. One important history is history of eczema or skin atopy in early infancy or the use of emollients. We all know that asthma belongs to a group of atopic disorders. We have skin atopy, that is eczema. We have allergic rhinitis. So that is again more important. Around 40 to 45% of allergic rhinitis or have concomitant asthma. So that is a very huge number. And therefore, we have to specifically ask about history of allergic rhinitis. Now, having allergic rhinitis in your history and examination not only helps us more towards making a diagnosis of asthma in under 5 child, but there is also a treatment implication in it, which means if we treat only the asthma part with inhalers and we don't treat allergic rhinitis, we are not going to achieve control in the child. And therefore, this history is very important because, as we said, 50 to 60% of asthmatics may have concomitant allergic rhinitis. The next is family history. So when we talk about family history, it has to be a 3-generation family history. We have to ask about the grandparents of the maternal and the paternal side, then the parents and all the first degree siblings of the parents, that is the uncles, aunts on the maternal and paternal side, and the first degree cousins. So family history takes a little bit of time. It should not be just a one-line question. Does anybody have asthma in the family? Now, Barnali madam will definitely tell in her counseling talk that whenever the doctor utters the word asthma, there is a little jerky response from the parents, okay, because it is still considered as a stigma or maybe a taboo to utter the word asthma. And therefore, we have seen commonly the moment we start uttering the word ghar mein kisi ko, before we complete the sentence, the answer is no. Okay, and therefore it is very important to ask about family history of in all the first degree relatives, and not only about asthma but all the atopic disorders, because the gene is same. Okay, it may manifest in a different way. For example, the child may be asthmatic, but both the parents may have allergic rhinitis and not frank manifestations of asthma. Certain antenatal factors, like if my mother was smoking in the antenatal period or there is a smoker at home, excessive use of antibiotics in the early life is known to precipitate features of asthma in the early childhood. Birth by cesarean delivery, low birth weight babies, small for gestational age babies, especially babies who are on oxygen in the early life, babies having bronchopulmonary dysplasia, ventilation, they may have increased predisposition to developing asthma. Breastfeeding is very important protective factor, and therefore babies who are top fed will develop early onset symptoms. Early life exposure to allergens, which can be aeroallergens or it can be tobacco smoke, as we said, into the immediate environment of the child. Air pollution, we all know, we have to ask, especially in metropolitan cities where our homes may be very close to a heavily trafficked area where there is a lot amount of air pollution. These are all things which we need to ask, which are going to support our diagnosis of asthma in our child. Now, which are the red flag signs, which means if any of these signs are present in our history or examination, we may not be dealing with a case of asthma. The diagnosis may be something else. So first is failure to thrive. By and large, an asthmatic child, if his nutrition is not compromised, why I say that? Because most of the times what happens in asthma is there are a lot amount of food restrictions which are put not only by the parents but the relatives. Don't give dahi to the child, don't give banana, don't give this and that. And therefore, if that is there, then only the patient will have failure to thrive. Otherwise, by and large, asthmatics do not have failure to thrive. Your chronic lung disorders like cystic fibrosis and all, or your primary ciliary dyskinesias with recurrent respiratory infections can come with failure to thrive. If the onset of symptoms is very early, especially in the neonatal period, again, less likely to be asthma. Repeated episodes of vomiting associated with respiratory symptoms, probably we are dealing with a GER or gastroesophageal reflux. A continuous presence of wheezing. As we said, asthma symptoms are characteristically recurrent, which means they come and go. There is an asymptomatic period in between, but if the wheezing is continuous, we have to think of other differential diagnosis. No response to controller medications, which will be seen in which will be seeing in detail in therapeutic trial. No association with viral URTIs. When the symptoms are different, you are not able to pinpoint any specific triggers. And if you get any focal lung signs, that is, as we know, asthma affects all the airways in bilateral lungs. So if you're getting signs only in one side of the chest, maybe we are dealing with a foreign body or some other differential diagnosis, or maybe a cardiovascular system which is presenting with a respiratory complaint. So these are the things which we should remember in our history and examination, which will take us away from the diagnosis of asthma. Now, when we talk about diagnosing asthma in less than 5 years, as we all know, it is a clinical diagnosis. So the GINA 2023 gives us something known as a probability-based approach for diagnosis of asthma. What is this probability-based approach? We are going to see. Now, how does it help? Number one, as we all know, since it is a clinical diagnosis, when we are explaining it to the parents, we are only telling, look, there is a probability or a possibility your child is asthmatic. We are going to keep your child under follow-up, and then we'll be able to come to a confirmed diagnosis a few weeks or a few months later. This will not only calm down the parents will be more accepting about about their child's diagnosis. And the most important thing, as we said, there is a lot amount of differential diagnosis. So if we have a probability, we start the child on therapeutic trial, and if the child fails the therapeutic trial, this probability approach always gives us a chance to revise our diagnosis if we have failed. So we can tell the parents, look, we had given a probability, but now this is not working. So we need to again relook into your child, reinvestigate your child to see whether we're dealing with some other condition other than asthma. So what is this probability approach? It gives us 3 boxes. So the first box says if the symptoms, the cardinal symptoms of cough, wheezing, and shortness of breath are lasting for less than 10 days during an upper respiratory infection, the child is getting only 2 to 3 episodes in a year, and there are no symptoms in between. If our child falls into this classification or this category of symptoms, few of them may have asthma. The treatment for these children would be SOS bronchodilators. We are giving SOS bronchodilators. These are the typical symptoms which the older classification used to label them as episodic wheezers or post-viral wheezers. The second category of children would be the same symptoms are now lasting for more than 10 days. They are having more than 3 episodes in a year. And in between also, the child is not absolutely well. He is having occasional symptoms. Some of them have asthma. And here we are going to give a trial of inhaled corticosteroid therapy. And the last box is all the signs and symptoms which are there in the middle box, that is more than 3 episodes, but the child is definitely symptomatic in between the episodes also. There are nighttime awakenings, and in addition, there is a family history of atopy or allergic sensitization in the family. This category, most of the children may have asthma, and again here we are going to give a trial of inhaled corticosteroid therapy. Now what we must focus on is, if we can see, there are arrows pointing to and towards and away from each of these boxes, which means these 3 boxes are not watertight compartments. For example, suppose if we have a 6-month-old or an 8-month-old baby who today is falling into the box 1, where we are giving SOS bronchodilators, but he has risk factors that he can develop asthma, we have to keep this child under regular follow-up. Over a period of time, the child may flip from box 1 to box 2 or maybe box 3. So that means that is the reason why these are not watertight compartments. So if our child falls in box 1, the diagnosis what we write on paper is going to be an under 5 wheezer with a low probability of asthma. If he is in the middle box, he will be labeled as an under 5 wheezer with a moderate probability of asthma. And the last one would be an under 5 wheezer with a high probability of asthma. In the moderate and the high probability, we are going to give something known as therapeutic trial or trial of ICS therapy. Now, what is this trial of ICS therapy? So once we have a moderate or a high probability of asthma, we start the baby or the child on budesonide, MDI with spacer and mask, depending upon the age of the child, 100 micrograms twice a day. We give it for a period of 3 months. At the end of 6 weeks, we again review the symptomatology of the child. Now, why 6 weeks? Because the literature says by and large, the full effect of inhaled corticosteroid takes 4 to 6 weeks, and therefore we review the child at 6 weeks. If at the end of 6 weeks, the symptoms are still persistent, first, what we should check is, was the medication being given to the child properly? The technique of giving MDI and spacer was right? Did we miss any comorbid conditions like allergic rhinitis? Were the triggers eliminated? If everything is in place and still the symptoms are persistent, then we must again review the diagnosis and start from 0 and go ahead, because we might be dealing with some other disorder. If at the end of 6 weeks, the symptoms are controlled, we continue the inhaled ICS for 3 months. At the end of 3 months, we abruptly stop. Here we do not taper, we abruptly stop the inhaled corticosteroids. If the symptoms recur after stopping inhaled corticosteroids, then we restart the inhaled corticosteroids in the same dose. And if now the child responds, this is known as a completed trial of ICS therapy. And we are almost sure that our child is having asthma, and then we continue the treatment forward. So this was up till 5 years of age. Now, when we talk about diagnosing asthma in children above 5 years of age, the 3 symptoms of cough, breathlessness, and wheeze remain. Additional symptom which an older child may come up with is the chest tightness or a heaviness in the chest, which obviously a child less than 5 years may not be able to express it. So The two main diagnostic features when we talk about diagnosing between 6 to 11 years is a history of variable respiratory symptoms. The variable respiratory symptoms remain same. Whatever questions we need to ask in the history for cough, wheezing, breathlessness, they also remain the same for children above 5 years of age. And then we have an additional, that is a confirmed variable expiratory airflow limitation, by which we mean we have to attempt a spirometry or a pulmonary function test and demonstrate it objectively. Now, what we must understand or remember is when we are contemplating doing a spirometry in any of our patients, and if it is a treatment naive patient, we have to do it before we start any ICS or any kind of therapy, because once the child is already on therapy, our spirometry results can be affected. So we won't be going into too much details of spirometry because that is beyond the discussion of this session today. But what we must remember is the ratio of FEV1 is to FVC. We all know that in obstructive airway disorders, the ratio of FEV1 is to FVC is reduced. And if it is less than 90% of the expected ratio or expected values for that particular age, gender, ethnicity of that child, we say that the FEV1 is to FVC is low in that particular child. And then we look at the FEV1. Definitely FEV1 is also going to be low in an obstructive airway disease. We do something known as the bronchodilator reversibility, that is they give salbutamol inhalation, and we again check the FEV1 after 15 to 20 minutes. If there is an improvement in the FEV1 of more than 12% from the baseline, it indicates a good bronchodilator response. So 12% is right now accepted in most of the guidelines. Some literature now also mentions a reversibility of more than 8% is good enough to label as a good bronchodilator reversibility. The spirometry is definitely the gold standard when you want to diagnose. PEFR, yes, if you don't have the facility to do spirometry, PEFR can be used. So when we do a baseline PEFR and after 15 minutes of giving a bronchodilator, there is an improvement of more than 20% in the PEFR reading, we can label that this child could be a case of asthma. But again, as we know, it is not a very foolproof method because the peak flow gives us the pulmonary dynamics or functions, especially of the upper airways or the large airways, where asthma, we know, predominantly will affect the medium and the small sized airways. Now, what about X-rays? Okay, there is always a fallacy to do X-ray for each and every respiratory case which we see in our OPDs or our wards. Now, X-ray has no role. So if we are sure about the clinical diagnosis of asthma, in each and every stable patient, we did not do an X-ray. We may do an X-ray, especially for an under 5 user who is an atypical user, and we are looking at other differential diagnosis. The child has failed trial of therapy. In a chronic cough, which is a chronic non-remitting cough with or without breathlessness, where we are looking at other diagnoses like tuberculosis, foreign body, CF, etc., there we might do an X-ray. If a child of asthma presents in an acute flare-up and it is not responding to our treatment of acute flare-up, possibly we are looking at an air leak syndrome like a pneumothorax or something like that, and there our X-ray is going to help. So routinely for each and every OPD case, whenever we are sure about the clinical diagnosis, we do not do an X-ray. Coming to the most popular testing, which is an allergy testing, where we get questions from people that should we do allergy testing. So first, what we must remember is the diagnosis of all allergic disorders is clinical. We have to have a good history. We have to have a good examination. Okay, and that is going to clinch our diagnosis. Yes, allergy testing is important. We do not say that allergy testing should not be done, definitely. But where do we do? If we read any of the guidelines, whether it be GINA, ATS, pediatric guidelines I'm talking about, the children with asthma who are uncontrolled, by uncontrolled we mean it is being diagnosed properly, the therapy is being taken properly, the comorbids are taken care of, triggers are taken care of, and still the child is not responding. So we are talking about beyond step 3, that is step 4 and step 5. There is a place where we do or we want to do an allergy testing, because there we want to know what is the allergen which is causing the symptoms or the uncontrolled disease in that child. And here, not only we don't stop at doing the allergy testing, but we also follow it up with an immunotherapy, which is a disease-modifying therapy. So we must remember that and the second important thing is, do not order an entire panel. Okay, take a good history, take a proper, try to, as far as clinically, localize what could be causing a problem and ask for those specific allergens. Why am I saying this is, most commonly what happens is, what we have seen as pediatricians is a food panel is ordered. There are 70 to 80 items tested in the food panel. And that 70 to 80 items, some 40 items are labeled as 1+ and 2+, and everything is omitted from the diet of the child. Okay, and what happens is, I don't know whether the symptoms of asthma are controlled or not, but the child definitely goes into a failure to thrive kind of a situation, and it becomes immunodeficient because of that. So again, it has to be a guarded approach. No role of total IgE, definitely, because it is not going to help. whenever we think about doing allergy testing, the gold standard is skin prick testing. Today, we have a facility of doing specific IgE testing. Our fluorescent enzyme immunoassay, that is, which is commonly known as Pediatop or Immunotop, is more specific and more reliable as compared to the RAST method. But however, it is more expensive. But as we said, skin prick testing is the gold standard. What message I would like to give here is choose your patients wisely where we want to do an allergy testing, and always take the help of another expert who is well versed in doing allergy testing properly and giving you a good diagnosis and putting the child on immunotherapy. So at the end, the take home messages from this talk is diagnosis of pediatric asthma is clinical, which is very important. For under 5 asthma, probability based approach is a beautiful approach where we can diagnose the patients, give therapeutic trial and see how the child responds to the therapy. Spirometry must be done wherever possible in all cases of asthma at the time of initial diagnosis. So whenever we can do a spirometry. And as we said, routine allergy testing is not indicated for each and every case. Choose our asthmatic patients wisely, which will definitely benefit with our allergy testing and the subsequent immunotherapy. Thank you very much.
So with this, thank you, Dr. Sushant Mane. It's a really excellent and crisp presentation. So we will move on to the next presentation by Bonnali Madam, Dr. Bonnali Bhattacharya. So it will be on the importance of counseling of parents of pediatric asthma. So once asthma is diagnosed, now the most important task is how we counsel the patient, and none other than Madam will be doing justice to this, because she is doing this in all Casper and we are learning from her also. Thank you, Madam. Please.
Thank you. I'll share my screen now. Is that visible?
Yeah,
yes, madam. Yes.
Okay. Good evening, ladies and gentlemen. I am deeply honored to be invited by the ICS to deliver this talk, and I'm delighted because this particular topic is something that is most close to my heart. Sushant has already taught us how to go about diagnosing a child with asthma. So with a better understanding of disease, we are able to diagnose early. With the armamentarium of drugs and devices that we have, which you all know perhaps more than us because you use that many various types of drugs and that many various types of devices, we are able to treat effectively. But what has dramatically changed disease outcome is the realization that counseling forms the backbone of disease management. And why the need? Why is our talk on pediatric asthma absolutely incomplete if we don't have a session on counseling? Is that, as Sushant mentioned, that there is some sort of a stigma attached to the disease. You know, they feel as though the lungs of their children is in some way handicapped. They go from denial to shock. Because why? Because there is ignorance about the nature of the disease. There is so much of myth surrounding the treatment because we use inhaled medication. There is inadequate trigger control measures. They discontinue controller therapy, having started and the child doing well because they feel, after all, it's medicine and after all, it's a child. So why give it? And then there are irregular follow-ups with the doctor because if we control well, they are going to remain well. And in becoming irregular, they stop it and boom, one fine day, they come in a flare-up. And there is also a lot of misinformation by allied systems of medicine. So, you know, that's also a little thing that we need to get out of that little manhole to be able to counsel them properly. Ladies and gentlemen, the two most important ingredients is knowledge and time. Knowledge we all have, but time we need to have because otherwise counseling is not going to work. There is no shortcut to success as far as counseling in asthma goes. And the more and the when you utilize the time to communicate, the best are your disease outcomes. We need to remember that as counselor, that parents have concerns. We have to allay their anxiety. We need to dispel their doubts. And we have to do this by transferring the knowledge. What you and me know, we need to let them know that in an open communication with active participation. It's not going to be that, look, I know it all. I've been doing it for so many years. So you sit and you listen to me. And so it has to be, because every family is different. Everybody's question, some of them are frequently asked, but they can ask you the strangest of things, and they have every right to, because they don't know asthma, they don't know inhalers, they don't know what are the triggers, So they might even ask you that, is it asthma or is it allergy? So you need to let them talk, and it has to be an active participation, and only then can we take it forward. Now, nearly 2.5 decades back, when I did my first talk on counseling, and I was a new kid on the block then, and I wanted to make it catchy and, so that it grabs the audience thing. And I devised these 5 A's of counseling in pediatric asthma. And it's not only not changed when I talk, I also see it being quoted, and it makes me really happy. Not because it's mine, but because if you follow it, you don't miss any heads of counseling in asthma, and particularly with parents whose children you are seeing with asthma. First, you need to help them accept the diagnosis of asthma. So far, they've heard seasonal cough, allergic asthmatic bronchitis, hyperreactive airway disease. It is written HRAD by very, very senior, very, very successful pediatricians, RAD. So this is what they have been told. As adult asthma doctors or as adult pulmonologists, sometimes I see some of your prescription and your asthmatic bronchitis and allergic bronchitis comes. But asthma is asthma. Even under 5 can have asthma. Initially, you might call it as a high probability of asthma, and that's the way my prescription goes. But asthma is asthma. Then we need to get them to agree to the inhaler therapy. Again, as pulmonologists, it's not a big deal, because most of your patients will accept inhalation therapy. But for us, parents are used to syrups, tablets, even injections, because they come for immunizations regularly. They are also okay with nebulization, because for every cold cough, their kid has been nebulized. So that's a safe box. It's an effective box. But this inhaler, so we need to communicate to them about the benefits of it. Then we need to ensure adherence, because it is not for a short time. They are okay with antibiotics. Well, some give for 3 days, some give for 5 days, but most times we actually need to give a complete course of 7 days, 10 days. There are diseases like a PPV where we need to give for 14 days too. That time also they'll roll their eyes. But if you're going to do a trial of therapy, the minimum period of ICS that you would use is 3 months. So adherence is a big deal. Then, as far as triggers go, we need to take a detailed history, because a lot of, and in children, the commonest trigger is a viral infection. They will tell you that my child was absolutely good during the COVID days. And since last June, that is when the schools reopened again, and he's again getting these problems. So we need to go into details to know the triggers. And as their treating pediatrician, and like I always say that in pediatrics, asthma is not a domain of a pediatric pulmonologist. Every pediatrician should know how to treat asthma. And as pulmonologists, because the moment they hear that it's asthma, they may come to you, and many a time their pediatricians may not be doing correct, and they seek you out. and then you need to also go about it this way with them, so that they at least stay with a doctor who knows about the disease. And it is our job to also tell them about that in the best of hands, you can have flare-ups and how to cope with it. Now, acceptance is the biggest hurdle, I feel. They will all ask you, are you sure? Because you see, in under 5, as Sushant said, we still don't have objective tools. You may say, but FOT you can do in children less than 3 years, but we still don't have predicted values. We still don't have cutoff values. In a bronchodilator reversibility, where you see the negatively, because the resistance increases, it can go down by, I think 35% is the cutoff, but it's still not validated. It's still happening. So are you sure in an under 5? So how do I combat that? Asthma counseling is not a eureka moment that, hello, this is done and now I'll start counseling. It starts from the time it is coming into your head that this is not just a cold and cough. So that's the time you need to start. So when I talk, I start writing all those factors that Sushant mentioned. And I say, while I was talking to you, I've written all this. And I've been ticking the boxes. That is why I say, if it's under 5, I'll say, the probability is extremely high. And we will put your child on a trial of inhaled corticosteroids, and I would explain it all to them. If a child is beyond 5 years, well, I definitely do spirometry for all those children, and it does help to show them. And while I'm doing this spirometry, I also get them to buy a peak flow meter, and I show them, this 20% that they say in resource crunch, I use it as a fulcrum to show them, because this is what they can understand and see, right? Though it's not just don't go thinking that, wow, we can do it. As pulmonologists, you all are great with spirometry, though doing pediatric spirometry is a challenge, and I do it myself. I don't even trust a technician to do it, because they don't know what to expect, and they sometimes don't have the patience. My child has not been breathless. Again, as adult pulmonologist, your patients will clearly tell you about shortness of breath, tightness in the chest. Sushant showed us that cough is a very important feature. Not all asthmatic child is breathless, and many a time they may not have appreciated a wheeze, which may be in there, but you may have heard it. But so asthma is not synonymous to breathlessness, though a lot of languages, like say in Maharashtra, Dama is like dum, or so they feel that he's never had dum, so why should you say it's Dama? Nobody, Sushant has touched upon it, that nobody in my family has asthma. Well, earlier I used to kind of get onto it in a very focused way. Now I am a little more inclusive, and I say, okay, cool. Go back home and ask your parents, and you may not know. And because I am going to treat your child, but I'm kind of throwing a stone in the dark. If you give me the history, I am more sure-footed. And will I treat? Yes. But ask them, don't worry. And in my case sheet, in my prescription has a good left side in which I'm writing all this, because lest they go shopping with another pediatrician or to another pulmonologist, they at least know that, she's made an honest attempt to go about her job. And sometimes patients don't understand the true value, but at least you have to make your case clear. So I write family history of asthma not forthcoming. In a little clinical study that we are doing at my clinic, we have seen 90% of the patients who have said no or I don't know have, in the next visit, when they formed a little bond with you and they've come back, they said, And you've forgotten about the family history. And you say, remember, you mentioned, actually, my mother said my brother had the same issue. Or, my mother had it. Or that my grandmother lost her life to asthma. So, family history is important with certain situations you may not get. Any tests to confirm? Yes, spirometry, yes. FOT is coming in a big way, and we are kind of now working on it, and we are hopeful that before long we will actually have our Indian values to share with everybody, and the pediatric values, so that we know for good that because there's a lot of thing on small airway diseases. So we see in bigger people also the FOT sometimes is picking up even better than spirometry. And in children, it is, the airways are anyway small, so probably FOT will come better. And allergy testing, I believe, like Sushant said, that not every kid needs to be subjected to an allergy testing. And like I said, that most of them are, the triggers are viral infection, or like in Pune, like in the last 3 days, my own kids who have been so stable are having mild flare-ups. Fortunately, they're able to pull them out at home, but that's because of the cloud cover. And of course, we've got Dr. Shravan Moitro with us today, and he's an allergist and immunologist, and we stand to learn from him on it. And then they ask you that, Doc, will my child be cured? I accept all that you told me. This is the time that I actually take use of the breath tubes, and they really help me with my counseling, and I'm sure most of you may have it. And so this is the time I tell them to say, look, this is a normal airway. This is the airway which is red, that is redness and swelling, like inflammation, in a language that they understand. This is what they know, right? Because they have gone to some doctors when they've been in spasm and they've been nebulized and it's open, and they feel, wow, that's the magic box. You go and it opens. So you need to tell them, this is the issue. This child is born with airways which are angry airways. So they are red, swollen, and if there is trigger, they're exposed to triggers, they go into this. So I need to address this. And I don't think I can ever make it this. I can't replace. That's why I'm not saying I can cure, but my control will be as good as cure. Only I'm not using that term. At this time, they'll say, what about homeopathy, ma'am? What about Ayurveda? They claim they can cure. Again, once upon a time, that's about 25, 30 years back, I used to get a little riled up, but age does add a lot of wisdom to one. So now I say that's not a pathy that I'm trained in, so I really can't comment. And if you do feel that they can cure, how about trying that before you, try mine? So that time, a lot of them will say that actually we are already doing it. And then I show them my true colors of Bengal tigress. So I say that if that did well, you wouldn't be sitting across me today. So how about doing this now? And because I don't want to give the credit of my pathy to another. And if this doesn't work, you go ahead. So we have people who've done fish therapy. I recently went to deliver a talk in Guwahati where, a pediatrician had come from Nagaland specially to attend the session. And he said in Nagaland, they give bat blood to kids who have asthma with the hope that it will get well. And so there are these alternate things happening all over, but we just have to be true to our science. And under 5 users with high probability does remain a challenge, but they are a remarkably good group to treat once you've been able to convince, because they show such dramatic improvement that they are with you forever and ever. You have to get them to agree to the inhalation therapy. Now, as adult pulmonologists, it's not a big deal. But for us, this is what they say. That, but aren't inhalers for adults? Because they have seen somebody in the family just pulling out an inhaler and doing it. Or, using the CT, a rotahaler. or using a savvy thing like a breath actuated. So they feel this is what they do. Why should my child be using it? Some granny from the village will say, you call me for injection and I'll come. So you need to tell them this. Sometimes they'll say, it's okay if it's inhalation medicine, we can do it by nebulizer. Then you say, you know why? You said inhalers are strong, and you're okay with nebulizer. Nebulizer, you're using 100 times more drugs. It's all getting deposited in the mouth. It's going to give you more side effect. So to your 200 microgram of budesonide, you're using 2,500. So that's, if you're going to do it 3 times or 2 times, it's as good as taking an oral steroid. But parents don't know, right? It's our job to explain to them. Are they strong? I show them a syrup salbutamol and an inhaler salbutamol. And I tell them that you tell me what's more, 2 milligram thrice or 100 microgram thrice. 2 milligram is 2,000 micrograms. They are shocked. I said, because it is targeted. I've already shown them the airway, right? So it makes my job easy. So I said, I have an issue with the eye, I'll put eye drops. I have an issue with my skin, I'll put skin ointment. Here I can target it. Why should I give oral things and let it go all over the body, and your child has increased heart rate, your child is irritable, your child is throwing up? So will it be addictive? They all ask that will it be addictive? Aadat to nahi pad jayega. So I say, it's not addictive. Even your tea coffee is addictive. But why should an inhaler be addictive? It's got nothing to do with the brain. But is it habit forming? Well, it's like brushing the teeth. That's a good habit. And it's like that. If your child needs an inhaler, you give it. If I have a young couple sitting across me using spectacles, I say, are you hooked to the spectacles? With the spectacles, you're like anybody else. So will it stunt my child? So, as pediatricians, something that we all should do is plot our children on growth charts. As an adult pulmonologist, I don't expect you to do, because 90% of my colleagues don't do it. But if we are plotting their growth, then we show them that actually once the asthma treatment has started, they start riding up. Because before that, their child is chronically ill, the child is stopped from eating everything. But here I'm guarded a little bit. I also see prideful prescriptions of Foracort 200, 2 puffs QID, Seroflow 250, 2 puffs QID. Can it stunt? Of course, yes, it can. Because that much more drug is just going into, you have minimal. When you give it an MDI and spacer, many a time they are not using a spacer, and and it's all up there. Especially if it's a peri-menarche girl, and you're giving them this, scary doses, then it can be thing. So when I see adult pulmonologist prescription, I see a big swing of pendulum. Either they are adult doses or they are very tiny doses, but a 10-year-old is like an adult dose, right? A child who is in the 6 to 10-year-old, but in step 4 is nearly getting, but we have to be extremely mindful of the doses. So the pendulum it has to be correct and appropriate. Now we write drugs and devices, again, controller medicine. That's the expensive drug, but we need to tell them that's the main medicine, and that it's individualized. Sometimes somebody in the family has a salmeterol fluticasole, and they feel we have one controller inhaler. The cha-cha takes it or the thing. So why use a budesonide for this child? So you need to tell them it's individualized. The doctor knows which step. So it depends on the age of the child and the severity of the disease that we choose which step and which drug. That is the challenge in pediatric asthma, that everybody doesn't go on ICS LAVA, and everybody doesn't go on MART, And, so it, for us under 5 is one treatment. So we actually have three types of treatment: under 5, 6 to 11, and above 11. So we need to be conversant with it, and we need to be able to tell the parents that what is the difference. And we need to tell them that reliever is for immediate care. It's for a short period, because especially the economically challenged, they feel if it's the blue or the green inhaler that helps, why bother about the pink or the brown inhaler? Because this is the one that helps. So you need to tell them that over the age of 5 years, it's not a good idea at all to use just the blue or the green inhaler, because it's kind of the entire thing changed in by, I think, Gina, 2020, that you cannot use Sava alone. And this is something that's happened that, pre-COVID, when they were under 5, and we said, you can use this on and off, and those kids stayed well. They haven't come now. They're 9 years, 10 years, and they've just been using this salbutamol inhaler, and they've come in mild flare, and it's exactly what they say. There is probably outpouring of eosinophils, or there is a blocking of those receptors. So, I'm actually seeing what Gina said, and that time you said, okay, really? And I'm seeing the kids who were under 5, they didn't come, during COVID, and now they're 7, 8, 9 years, and for last 7 days, they've just been trying to give the salbutamol, because we had taught them then when they were 4 years, and now they feel that he's not on any controller, but I can give the inhaler, but they've landed in trouble. A lot of children just hitting the emergency room and just being nebulized because they've landed in flare up, and they've actually been asthmatics 3-4 years back, but now only taking the salbutamol. Devices. As pediatricians, we choose. As adults, I often hear, I have a lot of friends who are adult pulmonologists, and before I started doing the talks with this, that time Chest Research Foundation, and now chest research training and research, I used to do the pediatric asthma leg for the adult pulmonologists, and they used to always say, show them all the thing and let them choose. No, as pediatricians, we need to choose the device for them, and across the board and across all our guidelines, we see MDI and spacer plus minus the mask is probably the best device in pediatrics. Of course, grown-up kids, we are okay with the breath-actuated inhaler, particularly the ones who are on MART, because again, we don't have it in all the formulation. But MDI with spacer, without the mask is, and I wish to tell you all something, that every child doesn't need the huff kick. That's the spacer mask. Beyond the age of 3.5 years, they don't need it. So again, I see adult pulmonologists, because it's a child, they feel that's the device to give. No, because you are increasing the dead space. Now we prescribe all this, we teach them the correct technique, we check the technique each time, every time, we tell them the common errors, because it is that much difficult. It's not just teaching an adult, it's teaching the parent to do it to the child. So it's via medium. Or even if it's an adolescent, they have to supervise, because it's a very difficult age. They know it all. They know it all. They're smarter than their moms, because they now go to convents and their moms are simple. They feel moms, they are the vernac medium, and, and the dad anyway is not at home. So they do all sorts of things. So every kid needs to be supervised. We need to put the dates on the cartons, because if the counter chamber is not moving and it's stuck or it's faulty, and it's stuck at 60, and so many kids have come with mild flare up because they feel it's happening. But if you write the dates on the carton and you said this will go for 1 month only, or this will go for 2 months only, you need to change around this date, they will be that much more. In this way, in your involvement, when we involve so much of ourselves with them, they're obviously going to come for follow-ups. And every time they come for follow-up, you must check their technique. Adherence is a Waterloo for all of us. Regular follow-ups, the first follow-up within a week, because you may have spent all this time and somebody has given them some gobbledygook about the inhaler and they've stopped it all, and they come after some time saying that, you did tell us, but somebody told us it's not a good idea, and we were doing this, and and my child is ill again. You assure them that you are going to step down. This is not going to be the same. That's the thing with pediatric asthma. See, with adult asthmatics, once you start, they have to take it for a lifetime. But so many, I would say 80 to 90% children below the age of 11 years, we are able to take them off their inhaler and counsel them well. I've stopped it now, but I've told you that your child has a tendency. We need to see. Now you don't need to come so frequently, but do come once in 2 months. And do remember that when he becomes an adult and if he has this cough not going or tightness in the chest thing, don't go about again giving cough syrups and antibiotics. Please tell the doctor then that you had asthma, or remember to. So I write it all in the thing so that if this child comes back after 5 years, they are not shell-shocked. I didn't promise them that everything is. I told them most likely it won't. But in case it happens, no big deal. We will do it again. Peak flow is an objective way of showing improvement. Maintain an asthma diary, which is the level of control, and encourage them. If they're doing well, tell them you're. And they say, every doctor has a grateful patient who says, now my child is much better because of you. I immediately say, stop. It's not because of me. It's because of us. You, my staff, and me. So that's it. And the triggers, we need to be very conversant. As a pediatrician, we always say that the commonest trigger is viral infection, followed by house dust mite, followed by, especially in a city like Pune now, where it's raining so much and it's cold, it's 22 degrees. We don't even need to use the fan. Like I'm sitting without any fan over my head. So if there is dampness in the wall, if there are cockroaches, you need to know. If there is so much of metro work happening, there is so much of construction happening, those are triggers, so that's why we say that those particulate matters are not going to be picked up on allergy testing and your child is sick. Ladies and gentlemen, what I want to say, 2 things. Exercise is a trigger, but do not stop a child from playing. Let them play. We control the asthma well. Remember another thing, that children can also have stress. It can be from bullying to, discord at home, to exams, and even a happy excitement like birthday can trip them. So we need to be mindful of it. I'm extremely proud of this. This is, I'm sharing, which is from Casper. We spent endless days. It is our job to tell every parent that in the best of hands, your child can have a flare-up. You don't panic. This is what you need to do. So everybody has an asthma action plan. We fill it up for them. We tell them what to do. And I'm sharing with you, probably, we are extremely proud of this asthma action plan. And if you all desire to have it, I will send it across to Indranil and he can share it with all of you. And I'm coming to the end of my thing, is that the golden rule in counseling is time. The second is patience. You need to have the knowledge. If you have no knowledge, no point in giving time and patience. So the most popular doctor need not be the best counselor. And you have to have empathy. You have to feel what they go through. A family which has a child with asthma. However, at times, is it a win-win situation for me all the time? No. In spite of all my efforts, in spite of all my passion, in spite of everything, I'm still not able to satisfy some. And they probably go elsewhere, and I just then pray that the doctor treats them as an asthmatic and is not just giving them montelukast and levocetirizine and nebulization, because then this little kid is going to become an adult asthmatic and is going to keep coming to your clinic. This little kid is going to grow up to have COPD, which is a far worse disease to manage than asthma, and is going to visit you. So when you have your asthmatics and your COPD adults, remember, some pediatrician probably didn't manage this kid well. And asthmatic children lead this kind of a compromised life. Can't eat this, can't play. You might have mothers say, better to go to school. Don't play in the evening because you come back breathless. They feel there can be a constant attack, like they're scared to go on holidays. According to WHO, the commonest cause of school absenteeism is asthma. These families, they feel there is something wrong with our kid, and we rob them of the daily joys of life. But if we all do it well, then of course all our asthmatics are going to be shining stars, because they are all winners. Thank you so much for a patient hearing, and I'll now stop sharing my screen.
Thank you, madam, for the excellent deliberation as you always do, and thank you. So I'll be requesting Dr. Atanu, who has a very good set of questions, I know, and we have a lot of questions coming from the audience also. So Atanu, over to you. We can have the panel discussion.
Okay, thank you. So after a thorough knowledge from Sushant and Barnaledi, we'll be moving to some quick questions. And I request my panelists to be, one second. It's not moving, I think.
So just cancel it and then again go from the, yes.
Okay, fine. Thank you. Okay. Thank you. So let's get into a real case. It's a 7-year-old girl with 3 episodes of cough, fever, and breathlessness in the last 1 year. If you remember, the box that Sushant had shown is already in the middle box. So probability of asthma is there. 2 or more episodes not associated with fever, as had also a history of wheezing in infancy, and it was of course triggered by exertion or activity, and we had history of infantile atopic dermatitis. That means that it had been diagnosed by a doctor, assuming that it has been diagnosed like that. And there was, of course, after we had taken a good history, there has been history of asthma in the family also. Of course, there is no specification as to who in the family had it, assuming that probably one or both of the parents had it. So, Indranil,
yes,
we all know that above 5 years, we need an objective diagnosis. So how do you go about this particular child and tackle this situation?
Okay, Atanu, thank you. And
Atanu, can I just say one thing, Atanu?
Yeah.
When you've chosen a great case, but when you said this comes in Sushant box too, no, those boxes are only under 5. Okay.
Yeah, sure, right.
If this child was 4 years, suppose it was a 4-year-old girl that you showed, and with all this,
right,
it would also be box 3, because you're giving allergic marker and you're giving family history, and you're giving, besides viral, also an exercise. So there are more triggers, and so if this is 4 years old, this would be box 3. But a 7-year-old definitely doesn't come in those boxes. Okay.
Right.
So
okay,
yes, Atanu, thank you. And as we see, this is a typical case where the history tells us everything of recurrent episode of cough, wheeze, shortness of breath, family history of asthma and atopy, and everything fits with a typical history of asthma. So yes, so what should be done? Should we right away start the inhaled medication with inhaled corticosteroid right now, or should we assess? So in this way, so yes, if we go by the definition of asthma, we need to have an objective assessment of the variable airflow obstruction, which we need to label it or stamp it as asthma. So we have to have a documented variable airflow obstruction, which we can do by many ways. The best way to do is spirometry. 7 years child, he can go for a spirometry. And we have the luxury to do an impulse oscillometry. We can have to do an impulse oscillometry, see the bronchodilator reversibility in spirometry and also in the impulse oscillometry. And if we can document that there is good bronchodilator reversibility, we can document and stamp it as asthma and at least tell that this is asthma to the parents and need to start the inhaled corticosteroid in this patient and then assess.
So, Indranil, you want to first do a spirometry and then start the inhaler.
So, objective assessment of variable airflow obstruction, which comes from the definition. If we go by any guidelines, they will tell us you have a typical history, you have to have a documentation of variable airflow obstruction.
So, if the parents want to start the inhaler just now, and they said that they will think about the spirometry later on.
So again, it is best to do the spirometry when they are 9. So that once they start with the inhaled medication, I may not get the reversibility in the best of its way. So best I will go to do the spirometry. See, most of our people, physicians, or if you take a pediatrician who are practicing asthma and have their asthma clinic, will have a spirometry with them. And it is best to have this spirometry done. And in our hospital also, the first visit when they have come. So they are 9 and the test for reversibility will be the best at that time.
Okay. Sushant, you had already pointed out that what would be the expected FEV1, FEVC in these diagnostic values. Do you want to impress on them again?
Yeah, so what we first see is the ratio of FEV1 is to FVC, which is reduced in case of an obstructive airway disease. So for children, the cutoff of this ratio is 90%. So if the ratio is less than 90% of what is expected, we say that the child is having an obstructive airway disease. Then we look upon to the FEV1 as a next thing, and we see the reversibility post bronchodilator. So if there is an improvement of more than 12% in the FEV1 after a bronchodilator response, we say it is a good bronchodilator response.
So if the spirometry is not possible because of because you're getting a report where you are getting restrictive pattern, do your hospital have a support system of impulse oscillometry? Sushant and
no, we don't have.
Yeah. Sushant,
we don't
please.
have.
You do have.
We don't have my institute. So we refer to an institute which is close by, and then we get a impulse oscillometry done.
Okay. Indranil, how often do you need it?
So yes, Tatanuda, I do have the luxury to do the impulse oscillometry. In fact, the FOT is also with me, but I'm telling you, impulse oscillometry is best for the child because the time taken to do the test is less in cases of the impulse oscillometry, the wire one. Okay. So I do have the luxury to do the test, at least document if there is an reversibility is there or not. And then I can at least tell the parents, you see that there is obstruction, and also that I can pick up the small airway obstruction, which is there in patients of asthma in the early part. And then I can tell that, yes, that is reversible, and you can stamp this as asthma.
Purnalidhi, with all these data, will it change the treatment pattern of?
I don't think it'll make it more correct. It won't change. Because you see, the case that you presented to us is a classic asthma. I'm absolutely with Indranil that we should, wherever possible, we should do a spirometry. It is only not done where we don't have it, right? Either we don't have the technical know-how or we don't have it. But the treatment, more or less, would remain the same because when we are picking up the steps of treatment, the spirometry or the FOT is only for diagnosis, but not going into the which step to start the treatment. The step to start the treatment would be more detailed history. I would want to know about the night symptoms. I would need to know the frequency of symptoms to go. So that way, yes. But like also what Indranil said is something that we all need to keep in mind, that across the globe, there is a lot of talk now on small airway disease. And so I feel impulse oscillometry is, of course, like he has the luxury but it is much more expensive than, say, having an FOT. But it is, this new kid on the block is here to stay. But spirometry as of now is the gold standard.
So, Patanuda, Soibal has an advantage of doing all those, and he has been doing for a longer time. We can have an experience what he has in doing this FOT versus impulse oscillometry in the pediatric age groups. Soibal?
Sure. Yeah, Dr.
Yes. Your voice is breaking, Soibal.
I can't see Dr. Mohit.
We cannot get you, Soibal. Just your, can you
unmute yourself again?
Just
Okay, till he comes in, Sushant, I put in a situation. Suppose this child comes in an acute exacerbation.
Yeah.
How do you assess that? First, do you need to do a spirometry still, or do you start the treatment first?
No, so like we all know, spirometry is effort dependent. So when the child is in an acute flare-up, the child won't be able to do a spirometry. So what we do is a clinical assessment, classify the child in what grade of severity is fitting into, whether it is a mild exacerbation or moderate to severe or life-threatening, and then start management immediately, depending upon what category fits into.
So after we handle the acute exacerbation, but that child is on inhalers. So now how do you do a spirometry now? Do you switch off the inhalers for a bit?
No, so we don't switch off the inhalers. In fact, when the child, if we recollect the guidelines, if the child who is already on controllers and trips and goes into an acute flare-up, in fact, it is said that it is suggested that we actually increase the dose for a couple of days to weeks of the maintenance medication. And then again, we come down, taper and see whether there is maintaining on that. So then we don't put off the inhalers, or we don't switch off the maintenance medications. What we can do is, once the child is completely settled and we come down to the baseline dose of ICS, again do a revisit first of the triggers, what could have possibly caused that episode. Okay, if or not we are able to pinpoint a trigger, if suppose we get a trigger, most of the times what happens, we had this in the vacation period, the children were traveling to their native places in trains and all, and they had a trigger. If you are not able to find, if everything is in a proper place, that there is no triggers, no comorbids, then we would like to repeat a spirometry to see actually what is the status of the airways, which means we are doing the treatment properly, the child is adherent to therapy, and still the child is not getting controlled or tripping. That means maybe the condition has progressed, or we are going into an advanced stage where the spirometry will help. So with that clinical background.
Okay. Shoaibal, you're there now?
Yes, yeah, and can you hear me now?
Can hear you.
Yeah, Shoaibal will need a quick take on iOS, and then
Yes,
we'll go
iOS. So Shoaibal, iOS versus FOT, which you are using it for a long time before even we procured it. So what's your concept in pediatric age group? Which one should be the choice preferred one?
See, basically, if you say the choice between the impulse oscillometry and a forced oscillation technique, obviously the impulse oscillometry fares better in a way that it takes lesser time, as you have just mentioned. But overall, you can say that the main sturdiness of the machine is more with the FOT, and the variations are less in the FOTs, so that we get more robust as the results as far as the parameters are concerned. But iOS, as you said rightly, so both has its own merits and demerits. It depends upon which one you use. So I'll say both are almost equally used in good and as far as it's concerned. The only point that you have stated is very well said, that whenever we have a patient with a clinical history suggestive of asthma, we need to document that asthma. So documentation, if we're able to do a spirometry with a bronchodilator response, it documents it. If you're not able to do so, and even if the spirometry, if it is normal, it has been shown that in many of the children, the iOS will show a reduced the resistance parameters mainly the R5 and the R20 or R5-20, and also a positive bronchodilator response. So if it is not shown in a spirometry, the impulse oscillometry picks that up. So if there is a facility where you can use an impulse oscillometry, definitely it's a better choice. The only disadvantage of impulse oscillometry is that we do not have predicted Indian equations for the children. So that is one of the major flaw, but many of the centers are working on that to develop a predicted equations and for the Indian children. So as we have them, so we are still now using the Wust-Wenz equations, which is a Caucasian equation, but that is one of the drawback. And maybe the centers which are using the impulse oscillometry, they are all going to come up very soon with predicted equations, which is going to increase the implications and its applications in case of the asthma in the childhood in the days to come.
Okay, Shaival, this particular child also had atopic dermatitis. We had been hearing a lot, particularly pediatricians are a bit apprehensive also about what tests to be done in such situations. Just a quick comment on skin prick testing and allergen-specific immunoglobulin, Shaival.
Yes. So as I was listening to Dr. Mane's talk, so he has said very clearly and that allergy testing should not be done for all the children who has the asthma. This is very, very true. Okay. Because all these tests, the skin test or maybe the specific IgE testing, they may be quite sensitive, but they have very low positive predictive values. So if you do not have a strong history, so if you just calculate through the Fagan's nomogram, you do not get a very high positive predictive values for this test. So it's very, very important that if a child like this, which I have shown in this case, who has a history of atopic dermatitis, this child is likely has embarked on what we call this is the so-called the atopic march or the allergic march. So it's very, very important to test this child for the atopy, because this testing the child for the atopy mainly to the aeroallergens hence may not be clinically applicable at this stage, but very well we can understand in the later day testing about the progression of the immunological sensitization, which can have an impact later on to decide whether this child is progressing immunologically and at the same time how the symptom is controlled. Symptom is well controlled, then it's absolutely fine. If the symptom is not well controlled, if the child is progressing immunologically, the number of sensitizers increases. Maybe you have the 4 aeroallergen positive at this juncture, maybe 6 months later, it becomes 8 or maybe 10. That means child is progressing, also developing new sensitizations. Then you have to search for the other options apart from the pharmacotherapy in which you can actually prevent this sensitization. So it is very important to judiciously choose a child. If this child who has a family history, who has a history of atopic dermatitis, we do not know the child that does not give a history of food allergy, but definitely this child is a candidate in which we can do the main important, the aeroallergen testing, that is mainly the grass pollen, the house dust mite, the cockroach, and maybe a tree or a weed pollen, and a fungal spore, maybe the alternaria or the cladosporium. At least 5 or 6 aeroallergen testing, and if there's a pet in the household, definitely a dog or a cat dander. And we can show that whether it's increasing or not. Another very important factor which has not been taken in the history, maybe it was not there, is a history of that associated food allergies, which has to be taken and is specifically asked into, but very importantly, it has to be kept in mind that if we talk about the allergies, if they have allergies to everything, it has to be a consistent thing, and there has to be a temporal relationship between the intake and the occurrence of the allergic symptoms, maybe 1 to 2 hours later. Anyway, so
just to stop you here, yes. And just one question. It's another important message that should be going. So if this child is sensitive to, say, dermatophytes and cockroach, and it is increasing, when should you advise an immunotherapy for this child, or should you at all advise an immunotherapy if the child is not really controlled with the pharmacotherapy that the child is getting?
Okay, so a very pertinent question. First of all, if this child is showing the positive skin test to dermatophobias, Farini and Teronicinus, and the cockroach allergens, skin test shows it is only a sensitization. We do not say it allergy, we call it a sensitization. Now we have to correlate it with the patient's history. Okay, so if there's history, if we find that there's triggers and which is causing the patient's symptoms to be uncontrolled, not well controlled by the pharmacotherapy, the first and the foremost thing that has to be done is the allergen avoidance. That is the environmental control. For cockroach, we do not advise the pharmacotherapy because, the immunotherapy, because that has very high protease content. But for the house dust mite, has been shown to have an effect on the disease control if it is a house dust mite triggered symptoms in that particular patient. So only having a house dust mite sensitization may not be the answer. We need to correlate it with the history. If there is mainly the morning symptoms, if there is symptoms when the patient goes to the bed, if there is actually there is too much of house dust mite exposure in the household, there's too much of upholsteries, there are soft toys, there are carpets, and usually the house dust mite symptoms occur all throughout the year, which increases a little bit in the winters, but it is all towards the perennial symptoms. Symptoms are mostly indoors. The patient is more unwell indoors. Patient is better outdoors. So these are the pointers towards that it could be a house dust mite triggered symptoms. And if the patient is not well controlled by the pharmacotherapy, this immunotherapy to the house dust mite is a choice which can be actually discussed with the parents, but obviously with the allergen avoidance measures taken carefully.
The routine testing for total IG, does it have any significance?
So it has been discussed.
Total IG has no role.
No role.
Yeah, total IG
and
has
food allergens all.
No,
it's a hype. Again, food allergen is a hype. Soibar has already explained, and Sant has already explained. So these are something which has already been discussed. So Atanuda, we can move on to the next.
So we have, so we'll move into another thing that had been discussed earlier also, that about FeNO. Indranil, do you want to take it?
Yes, please.
FeNO in diagnosis and monitoring, which do you prefer? Yeah.
So again, FeNO is an important tool which is in our hand, and it's a measurement of the inflammatory, that is basically eosinophilic inflammation that is going on in the airways. So there are different ways of measuring the inflammatory. Probably the best thing that can be done is to measure the induced sputum or just the sputum eosinophil, which is not available in most of the places except in a few centers, and it is difficult to interpret again. So the best thing of measuring the inflammatory is by using a FeNO. So it's a simple test. It can be done even in children above, say, 3 years or so, and there is a cutoff reading. So if it is thought that it is below 15 is normal. So in a child who is having respiratory symptom and the FeNO is more than 35, we can think that there is eosinophilic inflammation that is going on, and we will be more confident in starting inhaled corticosteroid in this patient who is having respiratory symptom, for example, cough or wheeze. So yes, to start inhaled corticosteroid, we can use FeNO. And again, if a patient is on inhaled corticosteroid, say, and the patient is not well controlled and the FeNO is high, either he is not using the inhaled corticosteroid or there is still eosinophilic inflammation that is going on. So if you are confident that the patient is using the inhaled corticosteroid, that means there is still eosinophilic inflammation and you need to increase the dose of the inhaled corticosteroid in this patient.
Well, Shushan, do you want to come in for FeNO?
Yeah, so I just want to add one thing. As rightly said, it helps us the diagnosis, which means the diagnosis first has to be clinical. The point in using FeNO as a diagnostic test, so we can use it as a monitoring test, which is right, because then we see the response. But if we want to use it as a diagnostic test, especially in smaller children, say less than 5 or less than 6, we must remember that there are a lot of other conditions where the FeNO levels go up. So then we have to be sure that the child is not having any respiratory or viral infection. Then the values also differ depending upon the age of the child, height of the child, many factors. Some the simple thing is excess of nitrates in the food, something like that. If the child is having nitrate containing excessive food, the FeNO levels may be up in the respiratory, the gases. So these all things have to be taken into mind if we are using it as a supportive diagnostic tool. So that is why if there was an article published by Pediatric Pulmonology AIMS in 2018, which said that the cutoff values have to be individualized for each patient. We cannot have a single cutoff as far as diagnosis is concerned. Monitoring, yes. So as if everything is fitting into place, triggers are ordered, we can use it for monitoring and we can go upon the ICS dose. So for diagnosis, we have to use it with a pinch of salt.
So Shoibal, how often do you use Pheno in your supportive diagnosis or monitoring?
One thing when we talk about asthma, we know that asthma has three important paradigms. One is the airflow limitation, which is reversible. Second is an airway inflammation, and third, obviously, is the airway hyperresponsiveness. So asthma is a clinical diagnosis that we all say, we all work on that. Without a clinical diagnosis, the other things does not fall into place. Obviously, spirometry is the main device by which we can show the variable airflow limitation. Now, when it comes to the inflammatory paradigm of the asthma, showing an inflammation, then it helps in actually choosing our inhalers, or maybe the inhalers that fit. But the most important is that whatever it is, we have to do an ICS for the adult patients in ICS LABA. So if it is the FeNO is raised initially in the steroid naive patients who have not been on any inhalers, if it is for the adult, if it is more than 50 parts per billion, then obviously we can, with great confidence, we can start the ICS LABA. But it does not mean that one who have a low this FeNO, we won't start them on the ICS LABA. So that is a very gray area in the diagnosis. But obviously, the main role of FeNO comes in the monitoring of the treatment. If despite the patient being on the treatment, the FeNO level is high, it shows either patient is not compliant with the treatment or we need to increase the dose of the inhaled corticosteroids. If the patient are on inhaled corticosteroids, not well controlled, and the FeNO level is low or the normal, then we have to think that patient is compliant, or maybe there are other endotypes of the asthma which is going underneath, so we may have to search for that. But interestingly, what has been found in a very recent paper, that there is not much correlation between the FeNO and the eosinophils in the sputum. This was done by one of the workers from Kolkata. So that actually intrigues and makes the entire picture difficult. Well, now we have a better surrogate, that is the blood eosinophils. But obviously, FeNO has a niche role in treating a patient with the asthma. First of all, if it is increased, definitely it gives us more confidence on putting the patient on the ICS, and obviously in the monitoring, it has a role to see whether the patient is compliant or not.
So combination of blood eosinophil and FeNO may be more better marker.
Yes, exactly.
In that way. So both are easy. In fact, only thing about FeNO is that it is costly. Blood eosinophil is rather cheap. Doing blood eosinophil, both of them together. But yes, in sputum eosinophil, which pioneers from Kolkata, Ongira Das Gupta and his team is doing it. So we have to learn that art, and unless that comes in, but in children it's also difficult to fetch.
Children is difficult. Children is difficult. Yes.
Okay.
So now we have another important controversial topic.
ICS LABA. Yes, Sindhunil, start the firing.
So yes, to start the ball rolling, should your position budesonide formoterol used in practice henceforth? So yes, I'm telling you, how do you position? Again, in patients saying when you are dealing with pediatric asthma, 12 years, again, in all categories, we can use budesonide formoterol or formoterol budesonide. We can use in GINA level 1, 2, 3, step 1, 2, 3, 4, all of these steps. Because the MUD therapy that has come, maintenance and reliever inhaler at the same way with formoterol budesonide, yes, it may be the preferred option. In children between 6 years to 12 years, yes, only in step 3 we can be confident in using this budesonide. Yes, but not in patients below 5 years, definitely. So above 12 years, yes, it's same like the adult one. 6 to 12, I'll be preferring only in step 3 and above, yes, as you Varnalidhi has already highlighted, and not in the pediatric age group below 6 years.
Yes, Varnalidhi, do you want to add anything?
I think Indranil said it very clearly. Just be repeating what he said. He was absolutely clear on this.
Okay.
So, but the real controversy is the bid addo with the blue inhaler. So how confident are we right now in the pediatric age group to bid away with the blue inhaler?
Okay. In the pediatric age group under 5, the blue inhaler definitely has a role. In every step of treatment when we are giving ICS, the reliever is your SABA. In the 6 to 11 years, step 3 onwards, only if you're using MART. In step 3, you actually have 3 options. You can have ICS LABA with reliever salbutamol. You can use double dose of ICS with reliever salbutamol, or you can have MART as OD formoterol budesonide, OD, and formoterol.
Very low dose, love.
Yeah, very low dose, which is once a day. So most of us pediatrician in the 6 to 11 years, if we are using ICS LABA, and which is step 3, is children who are waking up because of night symptoms. Like we teach them simply that it's very difficult to say more than 2 days in a week or more than a child waking up at night with pain straight away goes to step 3, and there you can use formoterol budesonide as the controller, but we are using the blue inhaler as the reliever. Because if I'm using MART, then the same thing, formoterol budesonide is only OD, and formoterol budesonide 1 SOS. So that kind of seems a little uncomfortable. So the blue inhaler, even in 6 to 11 years, is here to stay for us pediatrician. But beyond the age of 11, we are all using MART.
Madam, just what's your message about the preferred choice in this step 3 in 6 to 11 years?
At 6 to 11 years, preferred choice is formoterol budesonide 1 BD and salbutamol as a reliever.
SOS. Okay.
And step 4, of course, there you can, because they would be formoterol budesonide would be 200, 1. Then it is 1 OD formoterol budesonide. So that kind of becomes like a MART. But in step 3, my preference would be formoterol budesonide 1 and salbutamol as reliever.
Bernalidi, on the same, we had previously classifications as mild asthma, intermittent asthma. Those are not there in vogue now. But still, are these children who suffer, say, 2 or 3 episodes in a whole year, or they have, so to say, mild, initially where we had put them in the mild asthma, are significant life-threatening risk exacerbations are common in this age group?
You see, Otanu, that's the reason that the term mild asthma has been taken away, because they say 30% of the ICU admissions in asthmatics are these who have never been, who are now presently not on ICS and, are just been giving salbutamol. So when my patients ask me that, is this child's asthma mild? I don't step into that at all. I say he has asthma. This is the step we are starting and we are going to be good with it. So it is better not to use a term like mild asthma, because then they feel mild asthma can never land us into ICU. Mild asthma can also kill. So it's safer not to use terms like mild asthma.
So, madam, it was because of this. It was because of this that the updated GINA 2021 when it came,
Absolutely.
and the update was clear that don't neglect this mild asthma, and
Absolutely.
don't treat this mild asthma. Don't treat this mild asthma with only SABA, and that's the message that was going on. That is, don't treat this mild asthma with only SABA. Treat them with ICS and SABA. When you are using SABA, give ICS.
So when we finally take, because we as pediatricians have the luxury of taking our children off treatment, right? So when we are, say, taking them off treatment, we say whenever you're using the blue inhaler, you need to use
The pink one.
So we write it. Or at that point of time, maybe I would switch them on to a formoterol budesonide, that at least this is safe. So we have to hammer that not only into our parents, but we also hammer that into the thing of all colleagues, because they feel, oh, mild, that's no problem. They can just walk up to the clinic neighborhood and nebulize, or worse still, they have nebulizers at home. That a little bit they will nebulize at home with salbutamol. Nebulize, and then they land up in a DQ mismatch in an ICU.
Bornaladi, one take-home message for nebulizers for children.
So, nebulizers for children in asthma has a role only if a child is in acute flare-up with desaturation, where you need to use the nebulizer with an oxygen. Otherwise, for everything else, a MDI and spacer reliever is good enough. Home nebulization in an asthmatic should never ever be encouraged.
Yes, Shoibal, you want to
There's one thing I wanted to say is that, as we all know, asthma is an inflammatory disorder, and that inflammation is in the airways. So when we give these connotations of the mild, moderate, and severe, these are actually, they come from the what is the level of the symptom load in the patient, and maybe the level of airflow obstruction. But interestingly, one thing which has come up and as we know now, that the inflammation which is there in the airways is present at all the time, even in the patients who has a mild asthma, and that inflammation which increases is more in case of any triggers, the external triggers. The level at which the inflammation increases and the rapidity with which it increases, it remains the same whether the patient is in moderate, severe, or the mild asthma. So that entails one very important fact, that these patients can go into even having a mild, so-called the mild disease, can land up into a severe exacerbations. So always we have to keep that in mind, and we have to give the benefit of the inhaled corticosteroid or the corticosteroid treatment to these patients. And so this all, it's very important. Interestingly, a very few days back, I was reading one article which was published in the JACI in Practice very recently, and though it was done mainly on the adults and adolescents including, they have shown that as we all knew, that the increase of only the beta agonist usage, it increases the risk of the death from the asthma. But this new article, which has come very recently in the JACI in Practice from Japan, they have shown, the workers have filtered down a large number of the participants, that increased use of only the beta agonist or the bronchodilator, it increases the chances of a patient dying from a sepsis and a septic shock during an asthma exacerbation. It's a very interesting thing, as we all knew that the beta adrenoceptor and its ligand, that is the beta agonist, has an important role in the innate immune functioning as well. So now we know that if there's increased use of only the beta agonists and that is through these beta adrenoreceptors, it causes as an increase in suppression of the innate immune activity and leads on to more increased chances of the infection and the sepsis and the septic shock. That was the mechanistic pathway which was shown. So this is a very interesting thing which has come up.
So it is really interesting. Again, inhaled corticosteroid, which really should be immunosuppressive. As the beta-2 agonist is more immunosuppressing than the inhaled corticosteroid. So it's really interesting, and the message should go not only to the physician, clinician, the pediatrician, that inhaled corticosteroid is safe, not the beta-2 agonist.
Okay, so point well made. But Sushant, a parting message on this point. So where do you have the only situation where we can have giving bronchodilators, inhaled bronchodilators or SABA? What is that position that still remains?
As we said, inhaled bronchodilators we would give to an episodic kind of a picture. Like if the patient is having a wheeze which is persistent following a viral infection, we would give an inhaled bronchodilator. If it is occurring, say maybe 1 or 2 times in a year, that also, the common question which we are asked is, if the patient is having a viral wheeze for the first time, would you prescribe inhaled drugs? So definitely we would not be comfortable prescribing the inhaled drug because the parents would not be comfortable taking it. So for a first episode, we can have a syrup which is given in a small dose for a restricted amount of time. But if it is happening say twice or thrice in a year, but the other boxes of asthma are not ticked, that is, we are not looking at towards a moderate or a high probability, maybe there we would be giving a inhaled bronchodilator in those small kids alone, again with a sphincter and inhaler.
Right. Indranil, cyclosonide.
So again, this molecule is not really available all the time, but yes, it is a good molecule and it has been studied in the COVID time also. So if we have the facility of doing an impulse cytometry, seeing small airway disease, cyclosonide has a very good advantage over there. And we have used this molecule in COVID or viral infection where it has shown that it has some anti-inflammatory effect in doing that. So yes, in only a selected patients, if we can use for the small airway and for also for as an anti-inflammatory for viral.
Doses and availability.
So dosage again, I cannot give you the right dose. I don't know. Vanalidhi may be helping it in that way.
So when cyclosonide came with a lot of band baja, and then we had both the doses, the adult as well as the pediatric, and the pediatric they quickly removed because that time in 2013 a study came that they compared fluticasone, budesonide, and cyclosonide, and they said as far as symptoms and all go, they're all similar, but exacerbation was more seen in cyclosonide, and but now that everything is small airway disease, I do feel, and Gina, 2023, there's a lot of talk on small airway disease, and that is also why FOT and impulse oscillometry is also coming up in a big way, that it's picking up with. So I do feel that cyclosonide is going to make a comeback, but, and the other thing of cyclosonide, the advantage, because when it came initially, I did a couple of talks on cyclosonide, and some of my children were there on it, and it was that it was OD dose. So the adherence was excellent, but I don't know why it went away. So, it's amazing how fluticasone came and we had all, and now we don't use it because we cannot taper down. And same with fluticasone, it had two strengths, for the adults and for the pediatric age group.
80 and 160.
And they withdrew the pediatric within 6 months. So it's
Okay. So
Madam, it is coming back again. Now that we have indacateral glycopyrronium with cyclosonide also, so probably it may be coming back again.
Yeah. Vanalidhi, talking about band baja, so another molecule that had come with great band baja, and it is still there with great band baja, that is montelukast. So
I am not a montelukast fan at all. Except for children who have a really bad allergic rhinitis, and I have used and I have found them to be useful. And after I did the sleep course, and children who have obstructive sleep apnea with snoring, those children also have used montelukast, but a small fraction. What I dislike about montelukast and its usage is its combination with antihistaminic, and in syrup form, montelukast as a molecule is unstable in its syrup form, and you have montelukast and levocetirizine, name it all, like every company has a different thing. So I would say now that they have got this thing of neuropsychiatric, and anecdotal, but I've actually had patients who have spoken about night terrors. I've actually had patients who've said about aggressive behavior, and dental surgeons, physiotherapists and they said, do you think it's montelukast? And I have actually with great confidence said no, because that time Singulair was the biggest asthma selling drug in the world, and used to say there is anecdotal thing of suicidal tendency and nothing much about it, and I've brushed it under the carpet. And now when I see that neuropsychiatric thing, night terrors, aggressive behavior, parents have actually said. So once upon a time I used to still write. Now I am even more guarded, but I have never ever written the combination, and I always speak against the combination. And I hope people pick it up, but you see so much of montelukast and levocetirizine like prasad going with every prescription and every URTI.
So Atanuda, we have to wind up in the next 5
Yeah,
minutes.
the last.
I would like to add
Shoival.
one small thing. Yes, there is a small area where Montelukast still has a role to play, fitting of the asthma. There is aspirin exacerbated respiratory diseases, AERD. So if we talk with if a child or if a patient has an AERD, or for that matter, maybe the NSAID, exacerbated respiratory disease, NERD. So the Montelukast has a value as an add-on treatment in these patients along with the inhaled corticosteroids.
Absolutely, absolutely.
Okay. So we come to the last question about the various classes of biologics. Shoival, can you start the discussion?
Yeah, this is the talk of everywhere we talk of.
At least in adult pulmonology, we are discussing it a lot. In adult pulmonology, less in pediatrics.
Yeah, because basically now since we are going more towards the precision medicine and maybe the individualized medicine, so and the biologics are in the pipeline, they're coming. So maybe so in the severe asthma in adults, we know that we have to understand what is the endotype beneath, so whether it's a T2 high or the T2 low. So for the T2 high asthma, we have the options of the three biologics in India, that is the anti-IgE omalizumab or the IL-5, anti-IL-5 and IL-5 receptors. We have the benralizumab or mepolizumab, and it's going to come very recently is the anti-IL-4, IL-13, dupilumab. So there are now lots of evidences which is coming, and it shows that, but there are mainly three indications for which these are used. One is the reduction in the OCS dose. Second is the reduction in the exacerbations, and third is basically the control. So this is mainly the three, but most important reduction in the OCS, oral corticosteroid dose reduction in the exacerbations. But we do not know when to end. We can actually start the patient, but we do not know when to end with this biologics. And but the most prohibiting, in fact, is the cost. Okay. So which majority of our population.
So we can ride the horse, but we still are not very comfortable about coming down from.
Yes.
Okay. Indranil, closing remarks on this.
No, closing remarks means I'm telling you, this poorly controlled asthma or difficult to treat asthma or steroid dependent one, these are the patients. Again, as Shoival has already explained, the most important when we select an biologic or to the three biologics that are here, omalizumab, mepolizumab, and benralizumab that are available right now, the way to select is doing an IgE and the eosinophil. Yes, in patients who have high IgE, we select omalizumab, high eosinophil, with low IgE or with high IgE, mepolizumab or benralizumab is there. In none of these, there are other methods of therapy. That's the thing. In pediatrics, it is not that much used because these people, this is allergic asthma, these are well controlled on inhaled corticosteroid or an ICS LABA. But yes, we should be knowing it in selected patients for this. And more studies, more researches are yet to be coming up with the use of biologics in children also. So that's all from my part in biologics.
Varnalati, do you want to comment on biologics?
I truly have no experience, and I'm grateful to God I've not reached the stage where I'm needed to use, because as Dr. Moitra said, cost is prohibitive and we don't know when to start. I just have one kid who, who was non-adherent, and his father was the doctor in the corporation. And later I heard that he went to a pulmonologist and he was given omalizumab and he felt he was doing very well. And then I met them at a social function and he said, oh, we gave him 2 doses and even he was good. And no 2 doses of omalizumab can think. And we, the pediatric fraternity, had a chance of listening to Dr. Varinder Singh a week back on difficult to treat asthma. And when he mentioned, he says that probably a lot of those difficult to treat asthma in pediatrics are also children where we are, not doing a whole lot of things correctly, and we label them as steroid, this thing. So, and that was coming from a doyen and saying that I have just needed to refer 2 whom I thought may need and who also finally didn't end up needing. I ask this to all who've been in the asthma thing for a long time, but like in pediatrics, I do hear in pulmonology about biologic. Maybe we still don't know. Maybe I'll speak differently 5 years from now. But as of now, talking about the entire fraternity and not me, there are people who are misusing. But actually, it has no truth.
Another thing that I would like to add, a very small thing, that when we are to prescribe biologics to a patient, the adult patients, actually then they're like a child. Most important thing is that the counseling, because two things which goes with the prescription of biologics. One thing, they said that if they're taking an injection of 80,000 rupees, it's a panacea. That means it's going to cure their disease. That's what they get. And maybe if they're well controlled after few injections, they stop taking the inhalers also. And they again come back with in emergency with a serious exercise or submissions.
Yeah.
So without counseling, they should not know biologics should be prescribed without a proper counseling. And this is very, very important. And because otherwise, as there is no point in giving those drugs and making the patient discontinue the inhalers, basic ICS LABA, and making them landing into an emergency. And so that's of no point.
Yeah, Shaival, you might send those patients to Bangalore for counseling before you start your biology.
We should wind up right now. It's
over to Indranil. We had 2 hours of intense discussions. Yes. I think everyone deserves a dinner.
Okay, thank you everyone, and thanks to the audience also for their wonderful being with us for this wonderful discussion. So, what do you, Indila, for the closing remarks?
Thank you, sir. Thank you so much. The way you held the whole program together. And I think since we all wanted to do this program on pediatric asthma, you have formulated the whole program since the beginning with Otonu sir, of course. And thank you so much. We are really grateful to you both. And also to all our faculties, Sushant sir, Bornali ma'am, Shoibal sir, and Dr. Bhadro, Indranil sir. Thank you so much for making this program happen and taking out time from your schedule and being a part of this ICS endeavor. Thank you so much. And as for our viewers, thank you for joining us. Please join us in large numbers. You can always contact us at icsofficeexecutive@gmail.com. And you can interact with our esteemed faculties as we come up with new programs every fortnight. Before closing, I would request, can we please have the NAPCON video play? Thank you so much. So as you all can see, the NAPCON 2023 Delhi registrations have started. So don't wait, register yourselves now. You all can go to the NAPCON website and also ICS website. You all will get all the details. So register yourselves now. And as per our viewers, thank you so much for joining us. We will see you again when we come back with our next webinar on 11th of July on air pollution and its effects on respiratory health. See you on 11th. Thank you so much.
Thank you.
Thank you.
Thank you.